So we're very happy to welcome you to the 15th Canadian Symposium on Hepatitis C virus. My name is Colpitts from Queen's University, and I'm one of the co-chairs along with Justin Presseau from Ottawa. I'll turn it over to Justin in just a minute, but before then I wanted to give you an overview of sort of the structure of the day. So for those of you who have been attending for a number of years, the programming looks a little bit different. So we're now spread out over sort of 2 days. So we're going to have 2 sessions this morning. There's going to be a bit of a break in the afternoon. During that time, you can attend other Canadian Liver Meeting programming if you'd like. You can do some networking, you can take a break, whatever you prefer. And then we'll meet back here at 5:15 for another evening session. And then we have 2 sessions tomorrow morning that are more focused on vaccines, both from biomedical and sort of societal community perspectives as well. So with that, I'll turn it over to Justin.
Merci, Shay. Bonjour à tous. Je m'appelle Justin Presseau et de la part de Shay et moi, on est vraiment ravis de vous accueillir à le 15e Symposium canadien sur le virus de l'hépatite C. Notre thème cette année est « Nouveaux horizons en prévention » et comme vous pouvez voir, et comme vous avez entendu de Shay, nos sessions aujourd'hui et demain nous permettront vraiment d'explorer ces horizons ensemble. Et donc, sans plus tarder, on vous souhaite un bon symposium. Okay. Now, as we begin, we'd like to acknowledge the land on which we're gathering. We're meeting on the traditional territory of the Mississaugas of the Credit and the lands of the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. This territory is covered by Treaty 13 with Mississaugas of the Credit and continues to be the home of many and diverse First Nations, Inuit, and Métis peoples. We offer this acknowledgement with gratitude for their enduring stewardship of this land and the surrounding waters. And we recognize and seek to actively and authentically address past and ongoing colonial practices that have and continue to contribute to the disproportionate burden of hepatitis C among Indigenous peoples.
Okay, so it's my pleasure now to introduce Laurie Boros, who's going to open the day for us in a good way with the smudging ceremony. So Laurie Boros is an accomplished Indigenous vocalist, cultural leader, and community caregiver whose professional singing career has taken her across Canada and the United States. For the past decade, Laurie has served at the National Canadian Native Canadian Centre of Toronto, first as a youth worker and now as an Indigenous community culture engagement and event specialist. In this role, she leads ceremonies, sings, and drums at gatherings across the province, supporting community wellness through culture, tradition, and connection. Laurie is a proud mother of 2. Her daughter is a mental health nurse, and her son serves as a search and rescue technician in the Canadian Armed Forces. She is also a widow who carries her late husband's memory with strength and grace. Today, Laurie continues to bring her voice, teachings, and spirit forward to help open spaces in a good way, offering ceremony that honors both Indigenous traditions and also the shared responsibilities we hold in caring for each other. So Laurie, please.
Good morning, friends, colleagues, honored guests. My name is Laurie Boros, and I'm honored to be here with you today as an Indigenous woman to welcome you to the joint CanHelp conference today. Before we begin, I want to acknowledge the importance of everyone gathering here to advance digestive and liver health across these lands. Your work touches families, communities, and future generations, and I honor that commitment. We are gathered in the Tekaronta, now known as Toronto, the traditional territories of many nations, including the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. This land is part of the Treaty 13 signed up with the Mississaugas of the Credit, which now it remains to the many diverse First Nations, Inuit, and Métis people. So when we acknowledge the land, we acknowledge not only for the first peoples who have cared for it since time immemorial, but also our shared responsibilities to one another to future generations and to the natural world. I want to recognize and raise my hands to the conference organizers for centering sustainability this year. For Indigenous peoples, sustainability is not a concept, it's a way of life. Our elders teach us that every decision we make, we must consider the next 7 generations, and that the health of the land, the water, the animals, and the people is a one-connected system. As we gather to discuss digestive and liver health, the systems that process, filter, and sustain life, it reminds us that the earth also processes, filters, nourishes, and sustains all of us. I'm grateful to see this conference taking meaningful steps to reduce its environmental impact, honoring values that Indigenous communities have carried since time immemorial. On behalf of Indigenous communities and all those who call this land home, I want to welcome you to Takaranto. Welcome to these shared territories. Welcome to a place of learning, collaboration, and innovation. Welcome to the 30th anniversary of this important gathering, a milestone 3 decades strong. May the knowledge shared over these next few days bring healing, connection, and vision for the future. At this time, I'd like to offer a short prayer. And as you know, smudging is an Indigenous practice using medicine such as sage to cleanse our minds, our hearts, and our spirits. It helps us enter this space with clarity, respect, and good intention. If you do not participate in the prayer, you are welcome simply to sit quietly and just receive the good energy in a way it feels good for you. So I'm going to open with the prayer. Creator, bring us together in a good way this morning. We give thanks for this new day, for the breath in our bodies, and for the opportunity to gather on these ancestral lands. We honor the nations who have cared for this territory, and we acknowledge all the peoples who walk on this land today. Creator, we ask for guidance, clarity, and humility as we share knowledge, learn from one another, and work toward healing and wellness for all our communities. For those here who pray to God, for those who look to the universe, to spirit, and to their ancestors, or to their own inner wisdom, we welcome all pathways of belief into this circle. May the work we do over the next few days be grounded in respect, compassion, and responsibility to future generations. Creator, help us to speak with honesty, to listen with kindness, and to act with integrity. Creator, bless this gathering, bless the people who have traveled here, and bless the knowledge that will be shared so that it may heal, support, and uplift all people. I will now share the Strong Woman song. It's a song of strength, resilience, and community, and it's a reminder of the power we carry when we lift one another up. way, hey, hey, hi, oh. Way, hey, hey, hi, oh. Way, hey, yeah, way, hey, way, hey, hi, oh. Way, hey, hey, oh. Way, hey, hey, oh. Way, hey, hi, oh. Way, 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 hey, hi, oh. Way, hey, hi, oh. Way, 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 hey, hi, oh. Way, hey, hey, oh. Way, hey, hey, oh. Way, hey, hi, oh. Way, 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 hey, hi, oh. Way, way, hey, hi, oh. Way, 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 hey, hi, oh. Way, way, hey, hi, oh. Way, 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 hey, hi, oh. Way, way, hey, oh. Way, hey, hey, oh. Way, hey, hi, oh. Way, 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 hey, hi, oh. Thank you for inviting me, and thank you again for your commitment to health and healing, and I wish you a meaningful and impactful conference. Chimigwech.
Thank you. Thank you so much, Laurie, for that wonderful opening, helping us to open in a good way. Okay, so we are going to move into our first session this morning on prospects for prevention and elimination. And so we will have two invited international speakers and then a question period followed by two subsequent presentations. So I'd suggest for the first two presentations, you can hold your questions until they sit at the front for a little bit of a Q&A. But I'd like to invite Brandon Harney to come up and introduce our first speaker.
Bonjour, good morning. It's my absolute pleasure to invite our first speaker, Jason Grebely. Jason is a professor and head of the Hepatitis C and Drug Use Group at the Kirby Institute, UNSW Sydney. He's the president of the International Network on Health and Hepatitis in Substance Users and co-editor-in-chief of the International Journal of Drug Policy. Looking forward to hearing from you, Jason.
Can I just get my, slides are there. Hello, good morning everyone. Just massive thanks to the organizers. I was reflecting a little bit yesterday. It's been 21 years since I've been in the program. I was one of the first trainees, and this is the 15th conference. So Negla and I set this up 15 years ago. So it's just amazing to see it, growing strong. So we'll get stuck into it. So I would like to acknowledge the traditional custodians of this land, the Mississaugas of the Credit, the Anishinaabe, Chippewa, Haudenosaunee, and Wendat peoples. I work on the lands of the Bidjigal people and of the Eora Nation. Just really fortunate that I get to sort of work and play and live on those lands. Here's my disclosures. All right, so I've been set kind of a big task, but I'm going to try and cover a lot of ground. I want to start with discussing, well, where's the current burden of hepatitis C and where are new infections actually happening? What tools do we have in our toolkit to think about prevention and elimination? And what have we learned from some countries with successful HCV elimination programs? And I can't go through them all, but I've picked a couple. And given that I work in Australia, we'll hear a little bit about what's going on in Australia. So first of all, so what is the current burden and where are the new infections occurring? If you think about the global burden of hepatitis C, we estimate that about 57 million people living with HCV globally. This is a really nice sort of figure from Homi Razavi that was in this paper led by the Polaris group. And I guess I just wanted to sort of highlight that, that these were the sort of countries back in 2015 that China, Pakistan, India, Russia, Egypt, and USA that had the greatest burden globally. And with the exception of Egypt, which we'll talk a little bit later, it's really striking that actually China, Pakistan, India, Russia, and the US make up more than half of all HCV infections globally. It's really amazing. And if you think about sort of the burden, we did some work with Louisa Degenhardt, and of those living with HCV, about 5.8 million people are people who have recently injected drugs, so about a 40% prevalence. But there's also a huge number of people that have injected in the past, so we don't actually know what proportion of that population have a history of injecting. It's interesting. I really appreciate Adam Trickey and Aaron Lim and Adelina Artini giving me some of this data that they've been presenting, which is they've been trying to estimate the number of new infections due to a range of different sources. So first, looking at vertical transmission, we estimate that there's just under 74,000 people that acquire this each year. The highest is in Pakistan, so about 22%. And again, Pakistan, Nigeria, China, India, and Russia make up nearly half of all infections. We've got a range of different prevention strategies, but including prenatal screening and also offer of treatment during pregnancy. And Andrew Mendelowitz, Jordan, and Mia have put together a little paper reviewing some of this. In terms of unsafe medical injections, we estimate about 57,000 globally. Again, the highest in Pakistan, about 56%. And we do have a range of different prevention strategies, including scaling up those that prevent syringe reuse, reduction of unnecessary injections, training of healthcare providers, and ensuring adequate injection equipment supply. But the vast majority of new infections globally occur among people who inject drugs. Again, this is some really nice work done by Adelina, a former trainee in the program, demonstrating that about 1 million new infections occur among people who inject drugs. Same countries, US, India, China, Russia, can constitute the majority of infections, and partly US has the largest population size of people who inject drugs. So, I think, with these estimates, but a vast majority of all new infections do occur among people who inject drugs. So I'm going to focus on this. I think the one thing that, and Adeline and I were talking about this a little bit, one limitation is that we don't have estimates among people in prison, which obviously, there's ongoing transmission, so probably an underestimate of the total numbers of new infections globally. All right, so what do we have in our toolkit for HCV elimination? I've borrowed this slide from Jordan, so thanks, Jordan. It stays strong. We've got available prevention strategies, and I'll run through these. So needle syringe programs, opioid agonist treatment. We've got simple diagnostic tools, and we've got effective treatments. And combined, we really can use these tools to eliminate hepatitis C as a major public health threat. All right, so first, what do we know about opioid agonist treatment and needle and syringe programs? Well, this is a really nice review that was done by Matt Hickman's group, looking at the impact of opioid agonist treatment and essentially looking at studies of acute infection, demonstrating that OAT is associated with about a 50% reduction in risk of acquiring new infections. If we look at needles and syringe programs, this is looking at combination, and and I think it does matter because many of the countries combined either looked at high coverage needle and syringe programs or low coverage needle and syringe programs, but you get about a 71% reduction in risk with high coverage NSP in combination with OAT. One of the big problems, though, is that harm reduction services remain inadequate globally. This is looking at opioid agonist treatment coverage and needle and syringe program coverage among countries globally, with the number of people injecting this representing the size of the circle. But only 2% of people who inject drugs live in countries with both high coverage of OAT and needle and syringe programs. It's great to see Canada up there in the sort of upper quadrant. We also have simplified diagnostics that are now readily available. We've got dry blood spot testing or plasma separator cards. We've got point-of-care antibody tests with results in as quick as a minute. And we've also got point-of-care RNA tests. So we can now use these testing technologies to combine with treatment to facilitate elimination. And this is a nice systematic review that was done by Adam Trickey. And when they compared studies that looked at standard of care laboratory testing with point-of-care RNA testing, they showed that point-of-care RNA testing led to a 1.32-fold increased treatment uptake compared to standard lab-based testing. We've just done a cluster randomized controlled trial called the TEMPO study, looking at point-of-care testing and needle and syringe programs. And so this cluster randomized trial looked at people with current HCV that were recruited from needle and syringe programs, and we randomized the sites to either receive standard of care testing, dry blood spot testing, or point-of-care RNA testing. So overall, the proportion of people that initiated treatment within 12 weeks was 24%. But the treatment uptake was 38% in the point-of-care testing arm compared to 14% in the standard of care arm and 13% in the dry blood spot testing arm. So, individuals receiving point-of-care had nearly a four-fold greater odds of initiating treatment in 12 weeks compared to standard of care. And what's interesting is that this benefit is sort of realized in the first 4 weeks of treatment. You can see here in this sort of cumulative proportion of people initiating treatment. And I have data that I haven't shown yet here, but out to 1 year, sort of the 20% benefit is sort of maintained out to 1 year. So there's about a 20% increase. Okay, so what about treatment? How can we potentially use this as a prevention tool? I'm not going to steal too much of Natasha's thunder. It's hard presenting someone else's research back to them, but Natasha really was pivotal, and her sort of seminal work looking at treatment as prevention really led to a lot of activity in this space. And what we did was look at the role of treatment as prevention in 3 different settings with different sort of baseline chronic prevalences. And what she demonstrated is that with pretty realistic treatment uptake scenarios, you could get quite a large reduction in prevalence of hepatitis C at 15 years. She then also went on to sort of demonstrate that when combined with opioid agonist treatment and needle and syringe programs, if you combine treatment with these modalities, you get a greater prevention benefit. I know this seems like a little bit of a tricky figure, but I'll explain it to you. So on the y-axis is the number of annual treatments per 1,000 people who inject drugs. And on the x-axis on the bottom is the coverage of opioid agonist treatment and high coverage needle syringe programs. So let's take a treatment uptake of about 3% per year and a coverage of 20% of OAT and high coverage needle and syringe programs. So if you had those parameters, you would achieve, and in the boxes is the percent reduction at 10 years in prevalence. So if you have 30 or 3 per 100 person treatments and 20% coverage, you'd get a 50% prevalence reduction at 10 years. Now, just showing you how important this synergistic benefit is, if you increase your coverage of opioid agonist treatment and high coverage needle syringe programs to 40%, and you have a 4% per year treatment uptake, you can get a 70% reduction at 10 years. So just really important, demonstrating that these things in combination are most effective. Okay, so what do we learn from countries that have elimination programs? Well, it's a bit disconcerting. There's only actually 13 countries. This is most recent data from the Polaris website by Homi Razavi's group. But yeah, only 13 countries are currently considered to be on track for hepatitis C elimination. So I chose Egypt. Egypt is a fascinating story. I don't know, I think a lot of people will know, but so Egypt had the highest prevalence in the world. 7% of the population were estimated to have current hepatitis C. And what happened is they had schistosomiasis infection from the Nile River, and people were being mass vaccinated for this parasite, and essentially a large proportion of the population became infected. In 2014, the government developed a strategy for the national hepatitis response. Now, what was amazing is they actually developed local capacity to manufacture cheap generics. So this company Farco, and they managed to get the drug prices from about $1,650 US in 2014 down to $85 US in 2018. They implemented universal injection blood safety procedures and also implemented harm reduction, which was for a conservative country, it was amazing what they've been doing in terms of harm reduction. And then in 2014, and then again renewed in 2018, the president introduced national campaigns to offer free testing to more than 60 million people, resulting in 4.1 million people receiving treatment. It's just remarkable. And if you look at this national screening program, it's just amazing. So they had this ambitious target to screen everyone in Egypt that was greater than 18 years of age, so 62.5 million people. The testing and treatment was all paid for by the government, and then they divided the country into 3 screening phases, and each phase lasted about 2 to 3 months. Hospitals, primary rural health, insurance clinics, youth centers, mobile clinics, and each screening phase, just think of the scale, 5,800 to 8,000 teams, and they had teams of 3, a physician, a nurse, and a data entry person. And these screening sites were open 12 hours a day, 7 days a week. The clinical evaluation happened on site. Results were available 5 days later. They had fosbuvir declatosphere with or without ribavirin. And they did this over an 8-month period. It's remarkable. And they tested 50 million people in 7 months. They identified over 1 million people with current HepC, and 92% of them initiated treatment. So it's just really, really remarkable. When you've got political will and government investment, what you can achieve. And they recently were sort of noted as the first country to achieve the WHO gold tier elimination sort of goal. So good on Egypt. Australia, we haven't done as well as Egypt. We've done pretty good. A much different epidemic. So a majority of our infections occur among people who inject drugs and through unsterile needle syringe sharing. Really interesting, we had bipartisan political support, which led to a parliamentary inquiry in 2014. This led to this parliamentary report, which one thing that impressed me, I'm Canadian, in case you don't know, but one thing that impressed me when I went to Australia was just this partnership between government and the affected community and researchers and clinicians. And there's a series of roundtable meetings that happened in early 2015, which really led to much of the momentum that happened after the fact. But it was this multi-stakeholder collaboration that was really important. The other thing the government did is they negotiated with the pharma companies for a volume-based agreement with the government. People call it sort of the Netflix sort of model. And there was a commitment. We don't know the exact details of the deal, but we think that there's about $1 billion that was committed over 5 years. But it also enabled there to be no restrictions based on disease stage, provider type, or recent alcohol or drug use. So really quite amazing. There was strong existing models of care in drug treatment, primary care, and really critical prisons, which is absolutely essential for elimination efforts. I know I haven't mentioned them that much through this talk, but I just can't emphasize that enough. We had high coverage of prevention interventions, so NSP and OAT were in the 5th national strategy, and we had government funding of community-based viral hepatitis and drug user orgs. This is our national survey. We test about 2,000 to 2,500 people attending needle and syringe programs, and you can see here that the treatment uptake has gone from 11% in 2015 up to 78% in 2024. And this is corresponded with a reduction in current hepatitis C infection, so declining from 53% in 2015 down to 8% in 2024, so pretty remarkable. We also have the ability through matching by 2x2 name code, individuals that have repeat surveys within this cohort, and this is work that was led by Lisa Marr and Jenny Iverson, and essentially demonstrating that we've managed to reduce the incidence from 2010 to 2015 from 13.6 per 100 person years down to 5.4 per 100 person years in the more recent period. I think it's really important to note, so this is a 58% reduction in incidence, but this is in the background of high needle and syringe program coverage and also high opioid agonist treatment coverage. We've been running a program in Australia focused on point-of-care testing. Plan was to set up about 65 sites nationally, test 50 to 60,000 people across a range of different services, testings for anyone at risk of HCV or attending service, provide point-of-care testing for HIV and Hep B, and provides a range of different components. We've got access to the Abbott BioLine test and the InSTI 1-minute test and also the Gene Expert platform. We've now set up testing locations across 128 sites, and it's a bit misleading because there are actually outgoing testing in all sorts of places that amounts to about 510 testing locations so far. We've now got 128 sites sort of running across this, as I mentioned, 46 high-intensity testing campaigns across 26 prisons, and 480 operators have now received training. And this is just, we tested about just under 62,000 people. Prevalence in the community is 9%, 12% in the prisons. So this has led to the diagnosis of just under 5,400 people with current infection. Treatment uptake is 62%, a bit lower in the community, but it's important to note, again, 71% of the treatments have occurred in prisons. So this is now contributing about 14% of all the treatment nationally in Australia, and it does vary by state. So in some states where we've had more high-intensity testing campaigns running, like Queensland, about a third of the treatments are coming through the program. So we went and this is kind of hot off the press. So we did some modeling and health economics and said, well, okay, well, what if we continued the same numbers of tests that we're doing, so 25,000 a year through to 2030, and we also looked at sort of an accelerated scale up out to if we were able to attain up to 50,000 by 2030. And I just wanted to sort of highlight, because I know there's discussions around getting this up and running in Canada as well through sort of work led by Guillaume Fontaine and Mia Biondi. But so some of the modeling just to show that scale up of such a program, because you do get an increase in treatment and because of this prevention benefit, we've modeled that the sustained sort of scale up would avert just over 5,000 infections over 20 years. Because of these reduced infections, you save on treatment costs over time. It actually increases the numbers of treatments slightly, but you're averting infections, so you're not having to treat as many people. So it does save 47 million over 20 years, with the majority of that savings due to the treatment costs, and becomes sort of cost savings by 2032. So by combining sort of testing, now this is sort of, increased testing and scaling up treatment. What are some of the key features of the countries that have had successful elimination efforts? I've given you just two. I don't have time to go through them all, but I think some of the key features are presence of coordinated national strategies, political leadership, a real partnership approach across all sectors, having public health and social perspectives, and really having integrated service development with the ability for surveillance and research to be able to evaluate that impact. Having really broad models of care tailored to the epidemiology, so really thinking about the right test for the right patient in the right setting, and prisons are a really key component of that. And I think having had broad access to therapy with no restrictions has been really, really important. And then really intentional strategies to scale up testing and diagnosis. I do want to end on a bit of a sobering note. I think I've provided mostly good news stories. But if you look at what we're doing globally, again, this is the work from Polaris, with the existing numbers of treatment globally, we are barely keeping pace with the number of new infections. If you look at the figures here, they estimated that 7.5 new infections occurred and only cured 8.7 million. So we're just barely keeping pace. And so we really need to sort of amp things up if we're going to get there. So just in summary, I hope I've convinced you that the burden of HCV remains, that we really do need to, vertical and unsafe medical injection transmission should be eliminated. That shouldn't be happening anymore, not in this era. The majority of the infections that do occur among people who inject drugs through the sharing of injecting equipment. I think we have almost all the prevention interventions we need. We'll hear about the vaccine folks tomorrow, because clearly that would be helpful. NSP and OAT are effective prevention interventions. There's loads of evidence around that, but the problem has been delivering them at scale. Treatment can provide benefit, but I'm not sure if we can treat our way out of this, but maybe. I mean, Natasha maybe will tell us that. I do feel that we need greater advocacy for expansion of opioid agonist treatment and NSPs, particularly in the prisons. And I do think that point-of-care testing can provide us with an uplift in the testing and treatment that's required to increase that impact. So, and just in terms of the lessons from successful elimination efforts, Egypt has shown us elimination is feasible, but we need to do better. And I think that the community voice is really critical to raise awareness, both in the affected community and also in government. I think action will really require political will and government investment if we're going to sort of be able to do this, and that's across countries globally. Yeah, massive thank you. There's lots and lots of people that contribute to everything, so thank all them, and thanks again to the organizers, and yeah, well, thanks so much.
Fabulous. Thanks so much, Jason, for such a fantastic way to start the session today. I'll invite Brandon back up to introduce our second speaker.
Thank you, Jason. Echo that. Fantastic way to open it up. Good to see some data from back home after being here almost 2 years now. But yeah, very much a lot of work still to do. As Jason alluded to, our next speaker is Dr. Natasha Martin, who is an infectious disease economic modeller who develops dynamic transmission models to evaluate the impact and cost effectiveness of public health interventions. She's currently a professor in the Division of Infectious Diseases and Global Health at University of California, San Diego. And in a true tag team effort, she is the incoming president-elect of the International Network on Health and Hepatitis in Substance Users. Thank you, Natasha.
Good morning, everybody. Thank you so much. It's wonderful to be here. I want to acknowledge the traditional custodians of the land that we are meeting on and extend a huge thank you to the organizers for inviting me to speak. It's been a wonderful few days, and it's always really inspirational to see the outstanding work being done in Canada for hepatitis C elimination. I'm going to be talking about treatment as prevention for people who inject drugs. Has it met its promise? And these are my disclosures. So I want to start here about kind of defining what is the promise of treatment as prevention who injects drugs. And in fact, I'm going to say there were a few promises that were made by some theoretical modeling studies. And so I'll get into them in a second. But first, I'll start with the conceptualization. So in 2009, there was a very groundbreaking theoretical modeling study published in The Lancet looking at the potential impact of HIV treatment as prevention. The concept that expanded access to HIV treatment could reduce HIV incidence at a population level. Here, the modeling was done in South Africa. And we all know that 2 years later, in 2011, there was, of course, the groundbreaking HIV treatment as prevention, HPTN 052 trial that showed that treatment could indeed prevent transmission of HIV infection. So there was a lot of buzz around this. And our group was wondering, well, what about hepatitis C treatment as prevention? On one hand, we have the benefits that for hepatitis C, treatment is actually curative, and could there possibly be prevention benefits? On the other hand, with hepatitis C, of course, there's a risk of reinfection and high competing risk of drug-related mortality. So we're really interested in kind of looking at the balance of these two things. So we developed a theoretical modeling study, this is now 15 years ago, where we looked at the theoretical impact of treatment as prevention among people who inject drugs. And what we did was we simulated modest levels of hepatitis C treatment with the risk of reinfection, but the idea that if somebody, while somebody was cured, they were not able to transmit to somebody else. And we looked at sort of different levels of treatment, which are the different bars in this graph, and we looked in different low low, mid, and high chronic prevalence settings, and we looked at these relative prevalence reduction at 10 years. So the higher the bar, the better. And you can see that across kind of low to moderate prevalence settings, really substantial, kind of over 50% reductions in chronic prevalence achievable over 10 years. Less impact in higher prevalence settings where we have higher rates of reinfection, but still really dramatic impact that had not yet at the time been achieved through scale-up of harm reduction. This modeling study was looking at the impact of treatment with pegylated interferon and ribavirin, which were available at the time. Later on, Jason just showed this. We redid this work looking at the impact with direct-acting antiviral treatments. Now we see much higher bars because of the very high SVR rates. This modeling study indicating that maybe we could reach those 80, 90% reductions in incidence in some settings with modest levels of treatment. Okay, but we made another promise, and that was about the economics of this. So there could be population impact, but is it cost effective? Is it worth the money to treat people who inject drugs despite this risk of reinfection? I know this slide is complicated, but on the left-hand side, essentially what we showed was that, after, okay, a government may want to treat people with cirrhosis first to prevent immediate risk of decompensation and death, but after you treat those individuals, who do you treat next? Who do you prioritize? And at the time, the standard thinking was, okay, well, you just treat everyone with the most advanced liver disease, and then you kind of progressively treat people with less advanced liver disease for their individual benefit. And what we were showing here was actually if you prioritize early treatment for people who inject drugs, that can be your most cost-effective priority group next because of the potential risk of, because of the potential benefits of treatment as prevention. So what we showed is in sort of mild to moderate prevalence settings, treatment of people who inject drugs early, prioritizing those groups was cost effective and could prevent, on the right-hand side of this slide, kind of 1 to 2 onwards infections. And I thank Jason for presenting this really complicated slide. I would have done it differently if I had done this work, if I was doing this work now. But essentially, the last premise, I think, was really about combination prevention. So what can we achieve combining harm reduction and treatment? And what I'll do is I'll focus your sort of view on the top right of this figure. That's where those curves, you can see the 70% reduction in prevalence contour. If we want to achieve more than 70%, 80%, 90% reduction in prevalence and incidence among people who inject drugs, we really need to scale up both harm reduction and antiviral treatment. And then all of this work kind of supported the WHO elimination, hepatitis C elimination guidelines and targets. Originally, that sort of 80% to 90% reduction in hepatitis C incidence by 2030, and then later revised to incorporate specific threshold targets. And for people who inject drugs, that threshold was an incidence below 2 per 100 person years among people who inject drugs, and that was supported by these service delivery targets that looked at not just scale up of hepatitis C testing and treatment, but also scale up of needle and syringe programs, as well as people who inject drugs who are on opioid agonist therapy. Again, this combination prevention approach to achieve these elimination targets. So in summary, what was the promise? I think there were 3 key promises made: that treatment of people who inject drugs can reduce incidence, even in populations with high incidence and prevalence; that scaled up hepatitis C treatment as prevention for people who inject drugs can be cost effective; and that elimination of people who inject drugs, elimination of hepatitis C, among people who inject drugs can be achieved globally with scaled up combination prevention. So have we met those promises? Well, I think we have some really promising and strong evidence that treatment of people who inject drugs can reduce incidence. I'm going to talk a little bit about the work that we did in treatment as prevention in Australian prisons. This was a study led by Jason Grebely, Greg Dorr, Andrew Lloyd in New South Wales. And their study looked at the efficacy of scaled up DAA's treatment as prevention against hepatitis C in 4 prisons in New South Wales and Australia. You can see as they enrolled treatments, as they enrolled participants into the study, they tracked how much treatment that they had been provided. That's what's shown on the left-hand side of this slide. You can see there was a dramatic scale-up between 2017 and 2019 of hepatitis C treatment among these individuals. The blue bars showing the treatments that were provided directly by the study. The red bar is showing treatments that were provided either by the prison or in the community. So really dramatic scale up associated with what you can see on the right-hand side here, really important reductions in hepatitis C incidence, the top showing total overall incidence, the lower plots showing primary incidence of infection and reinfection. Overall, the incidence declined from just over 8 per 100 person years to 4.5 per 100 person years, essentially halving in that prison. And so we could see this treatment effect, treatment as prevention effect, both in the prisons, but also this cumulative effect of treatment in prison as well as in the community in Australia, shown by Jason here, in their community surveys of people who inject drugs, this decline in incidence by about 60% over time. And I wanted to re-emphasize his point that this is all occurring in the background of very high coverage of harm reduction, which is the sort of consistent theme we see across these settings. Georgia has also had a very expansive hepatitis C elimination program. We don't have sort of apples to apples comparisons, but what we can see among hepatitis C incidence among people who inject drugs, there was a multi-site study that was done way back in 1997 to 2001, where incidence of hepatitis C among people who inject drugs was about 16 per 100 person years. A more recent study that just came out in IJDP showed that among people who inject drugs in Tbilisi, incidence was less than 1 per 100 person year, indicating that at least in Tbilisi, they may have reached the elimination target of below that 2 per 100 person years incidence, and potentially facilitated by this substantial hepatitis C treatment expansion they've had. In Scotland and England, we also have seen dramatic increases in the provision of hepatitis C treatment for people who inject drugs, Scotland on the left, England on the right-hand side. I think the important thing to point out here is that there were increasing numbers, not just in hospitals, but really large expansions in outreach center, drug treatment clinics, as well as prisons that have facilitated this program. Over double of the numbers of people treated in England, reaching 40,000 by 2020. And so what impact has this had at a population level on incidence and prevalence? So this is both serosurvey, cross-sectional data in terms of HCV RNA prevalence among antibody-positive individuals. You can see the dots there in terms of the survey data, and the lines showing the modeling. So this is work that was done by Matthew Hickman and Peter Vickerman and the team at the University of Bristol, really showing that the scale-up of treatment that I just showed you, if simulated in their model, projected declines in viremia, which are concordant with what is seen here in terms of the declines in hepatitis C RNA prevalence among antibody-positive individuals over the time of the treatment scale-up. So what impact has that had on hepatitis C incidence? Well, the incidence estimation in the UK is quite uncertain. Here you can see very uncertain estimates that were generated through testing, finding individuals who are RNA positive but antibody negative as a measure of recency of infection. You can see quite uncertain on the right-hand side. You can see that in both settings, the modeling indicating that hepatitis C incidence has likely declined substantially associated with those increases in expansion and treatment. On the right-hand side, kind of indications that we may be observing this in England, with especially the most recent estimate of incidence showing a decline. Scotland, as you can see, still quite uncertain with their incidence data, and I think it really points to this question about whether sort of indirect estimates, because they're uncertain, can be combined with modeling to kind of give us the strength of evidence that we need to convince ourselves that elimination has been achieved. But I still think, strong evidence that England and Scotland are on the right track. So hepatitis C treatment as prevention, I think, has shown us some good evidence that this can work. Now, what about the cost effectiveness? So this was work done by Zoe Ward and the University of Bristol team, looking again at that England program and looking at, if with the observed hepatitis C testing and treatment scale among people who inject drugs in 4 regions of of England, it was that scale-up likely cost-effective. Now, unfortunately, the cost of the DAAs were commercially sensitive, so this team estimated, I think, conservatively, £10,000 per treatment course, and that kind of continued treatment until 2030, and found that in all 4 of the regions that they were looking at, the hepatitis C elimination program among people who inject drugs was highly cost-effective, 100% likelihood of being cost-effective across all their simulations, and a 5 to 30% likelihood of being cost-saving. And so we have actually just submitted this work, again led by Zoe, looking at, well, when could this program even have been cost-saving? So again, we don't know the exact negotiated price, which we vary on the x-axis here of a drug price from £1,000 to £10,000. And what we're showing on the left-hand side here is the incremental cost-effectiveness ratio. Across each line is each one of our 4 settings that we've modeled with those different prices. The right-hand side showing the proportion of the runs that were cost-saving. And so what we found is that hepatitis C treatments scale up in England had more than a 50% probability of being cost-saving if the treatments were below about £3,000 per treatment course, which is where we actually believe the negotiated treatment is likely to have been. So indication that it's not just cost-effective, but could potentially be cost-saving. And then what about global elimination? Well, unfortunately, we have a long way to go. This is work by Adelina Artenier, looking at global hepatitis C incidence among people who inject drugs in 2015 to 2021, so kind of where are we progressing in our elimination efforts. You can see the vast majority of countries are above that 2 per 100 person year threshold for elimination among people who inject drugs, and globally an incidence estimate of just under 9 per 100 person years. So we have a long way to go until this promise is realized globally. You've already heard from Jason that part of that is because we have very low coverage of harm reduction. This is data from that same systematic review, but it's actually broken down in terms of the 2017 review and a 2022 review to see how much progress was made between those 2 time points. So the top bar here shows NSP coverage among people who inject drugs, the proportion of people who inject drugs served by NSP in 2017. The second bar is 2022, so you can compare those. And then the lower 2 bars are coverage of OAT among people who inject drugs in 2017 and 2022. If you look at the green and the yellow, which are the proportion of people who inject drugs covered by either moderate or high coverage interventions, you can see that there's indication that there may have been improvements from 2017 to 2022, but still very low, with the majority of people who inject drugs in the red, with low or indeed no coverage of these interventions. As well as hepatitis C testing and treatment among people who inject drugs remains low. This is a slide I stole from Jason, a few of these slides stole from Jason, acknowledgement, with a global systematic review estimating that 47% of people who inject drugs who had ever received hepatitis C antibody testing and treatment coverage low, very sparse data in terms of hepatitis C treatment coverage, specifically among people who inject drugs. Where we have data, it's likely low, and most countries, as you can see on this map, really missing data in this population. In the United States, where I work, sadly, we are also not meeting the hepatitis C treatment need. On the left-hand side, you can see we were treating just about 100,000 individuals a year for hepatitis C. More recently, that's dropped to about 80,000, whereas we have about 70,000 new hepatitis C infections. Some estimates are much higher than that, so we're either barely keeping pace or actually far under treating in terms of just keeping pace with the number of new infections. We do have a proposed U.S. hepatitis C elimination plan and a bill that's stuck in Congress, has been sort of stuck in Congress for several years, proposing substantial amounts of funding to fund both point-of-care testing and treatment initiatives for hepatitis C elimination. But we're certainly a long way to go. And this is modeling work that a student of mine, Jessica Aranshima, and I have been working on in collaboration with the CDC. Here is simulations of new hepatitis C infections nationally in the United States on the left, and hepatitis C incidence among people who inject drugs on the right. The shape of those curves is slightly different because we've had big changes in the demography of people who inject drugs. We have had a big expansion of the initiation of injection drug use over the sort of 2000s, coincident with the opioid epidemic in the United States. Unfortunately, we also have had large rates of overdose mortality due to increasing contamination of our drug supply with fentanyl. So overall, what you see is, if you look on the left, we're certainly, in terms of new infections in the United States, only likely with our status quo to kind of just be back at where we were in 2015 by 2030. And on the right-hand side, you can see our incidence is well above that 2 per 100 person threshold. Now, if you look at the red sort of dashed line, that's a model simulation that looks at what impact could we have scaling up point-of-care testing and care coordination in harm reduction centers, which will be a CDC initiative. You can see that those initiatives could increase testing and treatment uptake, but we still have a long way to go. In fact, importantly, we still need to really focus on improving uptake of treatment once diagnosed in those settings. And if you look at the green line, that's showing what if we scaled up treatment to everyone who is within a year of diagnosis. And you can see that would cause a dramatic decline, but still actually fail to meet the incidence elimination threshold. We really need an expansion both of harm reduction services and testing initiatives to meet this elimination in the United States, especially because, without expansion of harm reduction, I think the harm reduction services are a place for us to find and diagnose people who inject drugs. So that's why we really need these coordinated efforts. And finally, I'll say a little bit about this drug supply issue. So some work that we've done in San Diego among people who inject drugs, a cohort of people who inject drugs, showed that fentanyl use among people who inject drugs was associated with hepatitis C incidence. This work was published in 2014 in Clinical Infectious Diseases. Use of fentanyl was associated with an increased seroconversion of hepatitis C by about 1.5-fold. And when we look at the trajectories, this is work again based on in San Diego, we see an increasing use of fentanyl among people who inject drugs over time on the left, and that being what we believe through our theoretical modeling associated with increasing incidence in this population. So I think these drug markets, especially in the US and potentially Canada, are really important in shaping what we see in terms of hepatitis C incidence. So overall, I think we have had hepatitis C treatment as prevention fulfill its promise in select settings with supportive governments, scale-up of testing and treatment, decentralized care, and high pre-existing coverage of harm reduction, but we have a long road to go until it meets its promise globally. We have inadequate harm reduction access, low testing and treatment rates, changing drug markets which complicate the issue, persistent barriers to care, a lack of political will and funding in many settings, and stigma and discrimination. An acknowledgement to my many collaborators, our funders, the CDC and the NIH, and just to close saying I'm really excited to be the president-elect of the International Network of Health and Hepatitis and Substance Users. I am really excited that our conference this year is in Czech Republic and encourage you to submit your abstracts by March 8th. Thank you very much.
Fabulous. Yeah, please come up, Jason. We've got about 10 minutes or so for questions, if anybody has any. I don't know where the mics are. Okay, there might be a roving mic, so if you have any questions for Jason or Natasha, please raise your hand and we'll get a mic to you. Oh, Brandon? Just in the front here. Thanks.
Thank you both. Once again, always great to see the sobering story. Jason, just wondering, so I'm an Australian now in Canada, and obviously, as you alluded to, Canada's trying to talk about point-of-care testing. Just wondering if you could talk about some of those numbers in terms of the treatment. Like, you're testing a lot of people, but the treatment uptake in community settings still seems pretty low. What do you think's going on there? Like, in terms of, is it the people are only coming in sporadically and then not coming back to that service? Like some of the numbers we got early on, like, were a lot better. It seems as though there's this like trend over time. I guess what I'm saying is that, we got the people who were like highly engaged. So now, like, what's going on and what do we need to do to get those numbers higher in terms of treatment?
I think it's a really good question. I have answers. So it's really interesting. So we've been doing some nice, led by Nat Taylor and Guillaume Fontaine, We've been doing some really nice process mapping, some implementation science work to try to understand what's happening at those clinical pathways. There's a couple of different bottlenecks. So the first thing is, an hour is still too long for a point-of-care test. So the first thing, and sorry, Safid, it's a great test, but an hour, so people leave. So, once they get that result, they may not get their results, so they may not stick around for the hour. So that's the first place where we're losing some people. So they're being lost and are not coming back for their test results. We're working through ways of how to improve that, incentivizing people to return back for their test result and thinking through other ways. The next bottleneck is, and I'm sorry, providers, but the next bottleneck is the providers. And we kind of have two groups. We've got more conservative specialists, and we've got GPs and or nurses who may feel less comfortable with prescribing. And so we offer point-of-care HIV testing and point-of-care hepatitis B testing. And what we're finding is at that, once somebody has a diagnosis, a lot of barriers. Look, in Canada, in Australia, it's very easy. You pick the phone up and you tell the central line, don't know cirrhosis, I want to prescribe this regimen. No requirement for HIV or Hep B testing or liver disease assessment. Now, we need to move our model to, does the person have decompensated cirrhosis? If yes, see a specialist. If no, treat. Then also ensure that you get your HIV and your Hep B and your liver disease assessment. But it shouldn't be a reason to withhold therapy. If you're at all concerned, we should be, you can provide, if you're concerned about decompensated cirrhosis, you can provide sofosbuvir, which is indicated. But either drug, anyway, so we should not, it's the best liver cancer prevention strategy is by treating this population. So I think that's where the bottleneck is happening, because then people are being referred off for phlebotomy and then they get lost to follow-up and don't come back. And so that's causing kind of a attrition across the cascade. So I think we're trying to work through that and using implementation science, understanding what are the barriers and enablers, what's working and why, and what's not working and why isn't it working, and then to design specific strategies to address that, whether it's patient or provider education, incentives, so on and so forth. So I think that's our next challenge to solve for all of us moving forward, because I think you're going to have the access to the point of care. It's great, but it's not going to solve all the problems.
Great. Any other questions? Just raise your hand and the mic will come around.
Thanks for fabulous presentations. I have a question. I was struck, Jason, by one of the first slides that you presented on the global burden of HCV and where it's coming from, with China and Pakistan, India, Russia, and we can see that some progress has been made in China, Pakistan, India. But I wanted to know if you had some insights into actually what's happening in those countries regarding HCV treatment or different initiatives around testing and so on, or do we? Yeah.
I don't. Naveed has some answers for some countries, maybe? Yeah. Yeah, I'll say I'm not really worried. Look, Nigeria has really done a lot of work recently. They've been working with Clinton Health Access Initiative and the government is very, very committed. We had a key person from the health department there at INSU. So I think there's real progress being made in Nigeria, both on their harm reduction and their hepatitis response. It'd be great to hear about Pakistan.
Yeah, in Pakistan, there has been now a strong political commitment. And they started a program of mass screening and setting up community clinics where they started to have a very simplified process for screening and then treatment. Screening using point-of-care testing, and previously they tested a model where screening based on point-of-care testing and then RNA flipping it back to the volume-based testing and then starting treatment. And using that approach in 1 year, they were able to treat more than 80,000 people within one province. But that is, of course, not sufficient. But that model showed that it's possible to scale up treatment and screening as well as treatment. Now they are going into community and screen people and then link them
Yeah, and thank you. And I'll just add that in India, also kind of like in Pakistan, and they've had a regional kind of response. So there's sort of regions within India that have had very aggressive hepatitis C treatment programs, and I think that was really supported by the development of low-cost generics that they were able to use for those programs that started their elimination efforts.
As the mic's going, maybe to Jordan, I wonder if you can reflect a bit on what are the circumstances that lead to the political will in places that the governments have bought in?
It all comes down to community. The number of times that it's been a patient advocate that has stood up in Parliament, that's what happened in Portugal, and just we will not accept, people dying. And I think we need, and there's some amazing community advocates in this room, and I think we need more of that in Canada. But that's how you get government will and commitment, is from the patient voices.
Great. Maybe last word to Jordan.
Fantastic presentations as usual, and amazing work. Like the work that you both have done and that INSU has done has really been phenomenal for the field. So thank you for everything. Natasha, I'm wondering, we've tended to focus on the cost effectiveness and potential cost savings of interventions. Given the political climate in many countries, including our own, that's shifted a bit away and sort of negative views around harm reduction, have you modeled the cost of pulling back harm reduction and showing the consequences of those decisions?
Yeah, thanks. That's a great question. So we have modeled out the sort of potential impact of cuts to harm reduction services, and showed that because of both the sort of impact of those services at preventing primary infection, but also the impact of those services on reducing reinfection among treatment, that can be devastating. And so while a setting could make progress with sort of combined treatment and harm reduction, if you pull back on the harm reduction, then you can lose progress and lose track, lose the ground that you've gained. And I think there's been some nice work, again, actually coming out from the University of Bristol, that showed that the cost effectiveness of this combination prevention approach it's more cost effective to have a combined approach than if you try to treat your way out of it. And Jason kind of alluded to this earlier in his statement. There may be some lower prevalence settings with low rates of incidence and reinfection where you could potentially reach elimination thresholds just through treatment. But I believe that the modeling has shown in the vast majority of settings, you really need this combination prevention approach. And in fact, that approach is the more cost-effective approach. And that you do worse when you're just relying on treatment. But the last thing that I'll say is, in terms of this idea that these economic arguments are changing and you kind of have to go with the times. I was having an interesting discussion yesterday about the sort of economics of hepatitis C treatment as prevention in prisons. And the importance, I know that there's important work coming out of groups here in Australia, and Nadine and others, that has been looking at the fact that treatment in prison can be cost effective, but also have a community benefit, and that the cost effectiveness in some populations may be less, may have less political weight because of those populations. And so now the economic arguments need to expand beyond that population to show the benefits that interventions in specific settings like incarcerated populations can have on the community. So as we're kind of developing these economic arguments, I think it's really important to kind of consider what are the decision maker priorities, what are the key features that will influence them that may be different than just the standard ones that we're developing through our economic evaluations.
So sort of building on that, but also taking, I know you've often focused on syndemic approaches, is if we want to address that, one of the elephants in the room is that many people who are treated and cured from hepatitis C then go on and die from overdose. And the harm reduction piece is not just about like linking people to treatment and care, but how can we use that to think about overdose prevention, and particularly when we're seeing like you showed really nicely about the fentanyl uptake. We have the similar issue here, but also with methamphetamine, we see like increase certainly in reinfection rates we've shown in people using methamphetamine. We have to find, that has to be sort of factored in. It's more than an economic argument. It's really like almost like a moral argument of how we address it.
Thanks, Marina. I couldn't agree more. I think that's an excellent point. I would say as sort of advertisement for modeling that I think one of the benefits of modeling is that you can look at the potential multifactorial benefits that occur from treatment. So not just related to hepatitis C, but related to reduction of HIV transmission, prevention of overdose, prevention of, we know harm reduction services also are impactful in preventing skin and soft tissue infections. A lot of other things that, have economic and health outcomes and benefits among people who inject drugs. So I think having a framework, and as we can build out both these models and these economic arguments that incorporate all of the benefits of these interventions, that's going to be more powerful. And, to my earlier point, kind of ensure that we're kind of capturing whatever is relevant to the decision maker or decision makers at the table. The one thing that I'll add and that Australia has done really well is collect information on the sort of upstream structural factors that are associated with these syndemic conditions like houselessness, like incarceration, right? And in those cases, interventions that are those structural interventions, I would say, that's when it's especially important to make sure that we're looking at the whole cascade of benefits that you could have across, these different syndemic conditions.
Tremendous. Yeah, this has been such a good discussion, and please join me in thanking our two first speakers in this great discussion. So I'm going to move us on swiftly into our next presentation. I'd like to invite James O'Grady up to the podium.
Good morning, everyone. How you doing? Good. Okay, good. So, hi, my name is James. Today I'm going to be presenting one of many projects from Métropole Sans Hepatitis C. As it's known, MSHC. It's a micro-elimination initiative that aims to make Montreal the first city in North America to reach HCV elimination through clinical community partnerships. The focus of today's presentation is a qualitative study whose goal is to identify priorities for people who use injection drugs and recent immigrants, and to identify specific interventions that could support HCV treatment access. It serves to inform future co-designed MSHC micro-elimination interventions. There we go. Okay, next one. So as we all know, hepatitis C represents kind of a unique public health paradox. We have highly effective treatments, yet the populations most impacted continue to have challenges in accessing care. People who use drugs and newcomers often face structural barriers that make traditional healthcare models more inaccessible. This work examines how hepatitis C elimination in Montreal can be realistically achieved through a community-focused, population-tailored approach. And Montreal offers a particularly instructive case. As a large, diverse urban center with established communities of people who use drugs and a significant and newcomer populations, the city reflects both the promise and the limitations of current HCV microelimination efforts. While DAA therapy is accessible within the healthcare system, linkage to care, as we know, and treatment initiation have leveled out across precisely those groups that bear the greatest burden of infection. This stagnation cannot be attributed to treatment unavailability, but rather reflects a structural mismatch, perhaps, between how we are able to deliver care and the social realities of those we're trying to reach. This study was premised on the understanding that effective microelimination strategies must be grounded in the lived experiences of service users, and that clinicians and community workers are equally essential partners in identifying where our current HCV care cascade works, and most certainly where it could be improved. Briefly, the data collection comprised 3 stages between November of 2023 and September of 2025. Interviews and focus groups were conducted in English, French, and Spanish, and were facilitated by a peer research associate with lived experience of both HCV treatment and injection drug use. All interviews were transcribed verbatim, imported into in vivo for analysis, and the analytical approach was informed by Braun and Clark, thematic framework, coding conducted between 2 independent reviewers, and our recruitment utilized convenience and snowball sampling in collaboration with supervised injection sites, day centers, community organizations, and the Chronic Viral Illness Service at the McGill University Health Center. So let's get to the fun part. So in total, we had 67 participants enrolled. Stage 1, we had 33 individual interviews with a mix of treated and untreated participants, which largely skewed towards people who inject drugs, a smaller number of people who are immigrants. Stage 2, 28 participants across 4 population-specific groups with a smaller mix of treated and untreated populations. And in stage 3, we had a total of 3 smaller focus groups, including 1 physician and 5 community workers. And taken together, the 3 stages provided data across the full care continuum, from initial awareness and individual decision-making to organizational capacity and system design. A little mixed up here. I have all my papers rather than on notes, so bear with me. Across the interviews, let's get to the fun part. Individual interviews, a clear pattern emerged. Competing priorities such as meeting basic needs made it hard for participants to feel ready to begin an HCV treatment. Housing instability, food insecurity, precarious immigration status, and the immediate demands of substance use created a context in which HCV, a chronic, slowly progressive condition, could not realistically occupy participants' primary attention. Compounding this were persistent misconceptions regarding the nature of contemporary HCV treatment, and despite significant advances represented by DEA therapy, fear associated with interferon-based regimens, characterized by long duration, severe side effects, variable efficacy, remained prevalent and influential in participants' treatment decision-making. This suggests a critical gap between how our treatment innovation and community-level health knowledge, and with implications for how public health messaging is both designed and disseminated. Stage 1 also identified a key facilitating mechanism, which was peer-led education. Peer testimony functioned as not merely as information transfer, but more importantly, as social proof. It demonstrated that treatment was feasible with participants' existing life circumstances. And comparisons to HIV, although not universal amongst participants, were notable. HIV has benefited from decades of sustained public health investment and community organizing, resulting in a degree of health literacy that does not yet exist for hepatitis C. And participants use their existing knowledge of HIV to contextualize the virology, treatment, and even severity of HCV. So this quote at the bottom too, it's gotten to the point where it's better to get HIV than hepatitis. At least you have good doctors who take care of you afterward. You get good medical care with HIV, which is something that was very surprising to find in this study. And at the group level, among immigrant and newcomer participants, navigating Quebec's healthcare system emerges a significant and multifaceted challenge, one that operates both independently of and in addition to their hepatitis C care needs. Participants articulated a clear expectation that the government bears a responsibility to proactively engage with arrived populations around hepatitis C, rather than expecting individuals to self-identify and to seek out services on their own. And culturally matched peer support was consistently proposed as the most viable mechanism for bridging this gap. And among participants who used drugs, focus group data reinforced and extended stage 1 findings regarding the competing priorities and the importance of peer relationships, and also the value of community organizations in mediating access to care. Peers and community workers helped open new pathways to care by building service users' knowledge and trust in pursuing treatment. And the stigma data from stage 2 is particularly instructive. Negative healthcare encounters were frequently attributed not to malicious intent by clinicians, but to inadequate clinical training in working with people who use drugs, a gap that manifests, as we can expect, as discomfort, implicit bias, or perhaps a failure to apply harm reduction principles in clinical interactions. The consequences of such encounters extend beyond the individual and within close-knit community networks like people who live on the streets, people who use injection drugs. Adverse experiences are rapidly shared with the potential to erode trust more broadly across wider populations. Wow. And amongst professionals, we see that the overdose crisis, as we mentioned before, has fundamentally restructured organizational priorities within community settings. Participants described a context in which the immediacy of the overdose response has necessarily displaced attention from resources from STBB outreach, including HCV. And second, the question of task shifting was raised with considerable nuance. And while there was broad agreement between the clinician and the community workers that some community organizations are well positioned to take on expanded roles, including rapid testing or low barrier prescribing to improve linkage to care, Participants were emphatic that structural task shifting without commensurate resource allocation is not a solution, but rather a transfer of burden. One participant articulated this clearly, saying, "We're part of the solution, but we are not the solution." This distinction is essential for policymakers designing community-integrated care models. I'm all mixed up. And thirdly, participants highlighted a systemic consequence to adverse health experience that is often underappreciated. When service users encounter stigma, dismissal, or inadequate care in emergency or acute settings, service users typically then avoid seeking care altogether, leaving community workers to respond to situations that otherwise would involve earlier clinical intervention. And so, what now? We have all this information. What are the implications for the experiences of both people who use drugs, newcomers, and clinicians, community workers, this whole package that makes the trajectory of care possible in the first place? And we converge on a central conclusion that gaps in HCV treatment uptake appear driven less by the availability of treatments, but in how individuals are supported from diagnosis to cure. And the barriers identified, persistent misinformation, competing structural priorities, fragmented care pathways, and the erosion of trust through stigmatizing encounters are not amenable to individual level or biomedical interventions alone, but require multifaceted responses. And our findings support several evidence-based policy directions. Firstly, the formalization and resourcing of peer roles within HCV care pathways. This includes accompaniment programs for recent immigrants, peer outreach for people who use drugs, models with demonstrated efficacy in similar contexts. And secondly, the integration of HCV testing into existing STBBI testing. Our participant in stage 2 identified this gap directly, saying, if I don't know HepC exists, how am I going to know to ask for it? Routine opt-out testing at existing service touchpoints addresses this structural barrier without requiring additional patient navigating, specifically for immigrants who may not be marked as at risk for hepatitis C. And thirdly, the adaptation of public health messaging informed by HIV advocacy. The U equals U campaign, for example, undetectable equals untransmittable, fundamentally transformed clinical practice and community knowledge around HIV. An analogous communication strategy for HCV, emphasizing curability and destigmatizing treatment engagement, represents an underutilized lever for raising awareness. And lastly, or second to lastly, we're almost done, expanding medical professional education, providing nursing and medical students the opportunity to develop hands-on experience in community organizations, serving the populations most affected by HCV. These practicums, to say, could foster cultural humility, reduce stigma, and prepare clinicians to deliver HCV care that is responsive to lived realities. Now, lastly, embedding low-threshold HCV treatment pathways within community settings through clinical community partnerships, the clear one we've been talking about all morning. This included testing, standing orders, or simplified prescribing protocols, mechanisms that could enable community-based programs to initiate treatment without requiring patients to navigate multiple appointments or additional navigation. In conclusion, the evidence generated by this study affirms that hepatitis C elimination in Montreal is an achievable objective, but only if the care trajectories we design are responsive to the realities of the populations we're trying to reach. The gap between diagnosis and cure is not primarily biomedical. It is social, structural, and systemic, and addressing it requires the same interdisciplinary commitment reflected in this study, bringing together lived experience, clinical expertise, and community knowledge to build something that works for everyone. Our team is using this data to inform future projects and interventions, which currently include the SCALE study with Dr. Guillaume Fontaine, a national initiative designed to provide robust evidence for scaling up point-of-care hepatitis C testing for key populations. We're also in discussions with community organizations in Montreal in developing a POC testing project and transitional housing. Lastly, I just want to thank everyone who made this study possible, including our team, the community organizations who facilitated this work, and of course the participants. In this QR code, you'll find our email, so please get in touch with us if you have questions or want to talk. So that's it. Thanks so much.
Okay, let's, if anybody has any questions for James, he'll be around, I'm sure, so you can catch him in the break. And just passing it over now to our last speaker of the session, Tamara Barnett, come on up.
Okay, great. Hi, everyone. I'm Tamara. I am the Hepatitis C treatment coordinator at Kool-Aid Community Health Centre, which is in Victoria, BC. I'm also a CanHepC trainee. Recently went back to school, and I work on HepC treatment in pregnancy and HIV prevention, as well as HepC self-testing. These are my disclosures. I live on Vancouver Island, which is in Victoria. I was also born there, and the Kool-Aid Clinic is located in Victoria too, which is the traditional territory of Algonquin-speaking people, specifically known as the Songhees and Esquimalt First Nations. So I think that Kool-Aid is an expert at micro-elimination, and the presentation that we just had really speaks to me as well. And I think that when you look at micro-elimination, and you've been doing it as long as we have, we've had a HepC nurse-led treatment program since the old interferon days, so a very, very long time. I think it's critical when you get down to actually thinking that you're almost eliminated hepatitis C in the South Island, that you really, really understand what's going on in your city. And in BC, we have a very unique context. We have an absolute horrific overdose epidemic. We have a housing crisis. Back when I first started street nursing 17 years ago, I was able to phone up a housing site and say, I've got a patient being discharged from the hospital. They've got dual lung pneumonia. I need them to have a house tonight. And they would get housing. And now we have a 10+ year waiting list, which is absolutely horrific. I really appreciate Naveed's lectures in CanHepC because he talks a lot about syndemics. And I think that when you look at situations like Victoria, downtown east side of Vancouver, we have to also realize that we're not treating hepatitis C in silos. There's lots of other things going on. I'm showing a picture there of bylaw officers, police officers, and it looks to be like a dump truck. And so what happens in our homeless communities is that a dump truck pulls up at an unknown time and an unknown day, and then the area gets cordoned off and people need to either move their stuff in about 5 to 10 minutes, or it goes in the dump truck, including your medications, and off to the landfill. So that situation is very important to understand, and I think the other situation is important to understand is that we have extremely toxic drug supply that now has many different substances in them, and a lot of those substances now have never been tested on humans, such as veterinarian sedatives and things like that. One problem we're also noticing in Victoria is a lot of the downtown business community stores, shops, grocery stores are starting to shut down. And I think that I'm showing Wildflower Bakery because I think that's a great opportunity for the community to figure out a way to stay. And Wildflower Bakery has been on Pandora Street for 20+ years. And what they recently did, which I also really appreciate, is allowed the community to graffiti or do artwork on the walls. And so that's just a picture there of one of our patients who has passed away. And that's a sign of showing that the community is grieving. And I think that's also important to understand that our community is constantly grieving all of the time. One other thing I want to mention is that many people in Victoria, because of the switching drugs constantly, is that people have switched from injecting to smoking. And so what does that actually look like? So that's a hammer pipe, bubble pipe, crack pipes, hooked up to tubing, and then you would smoke it that way. Those are expensive harm reduction equipments, and we can't always get as many as that we need. So when we're handing it out and we run out, then people start asking for needles. And so I think that's also important to understand. When we see bylaw, police, or other citizens stepping on glass crack pipes or bubble pipes, that's also a problem because we don't have enough already, and so now the community will switch again back to injecting. When things like that happen at our shelters, we need to be able to mobilize our HepC treatment program into those sort of situations and make sure that we don't see reinfection and that we're constantly testing in those areas. So Kool-Aid Community Health Centre, you've probably seen me use this slide before. It's a multidisciplinary team. We have many nurse-led programs. I don't think we've always been great at saying we also work in brothels, we work in apartments where people do sex work. We also work in the evening, offer outreach van in a park in town where gay, bisexual men who have sex with men frequent. We show up there in the dark because it makes it more inviting for people to come and see medical care when they want to be anonymous in the dark. And so I also get asked the question, how do you have healthcare providers that will work after hours? Because nobody ever wants to work after 5 o'clock or 4 o'clock. And I think when you do fun things like work in brothels or you work outside, in those sort of situations, I really enjoy those kind of nights. And so it's just easy to go and do work like that. And so I think that's also a way of engaging healthcare providers if you're out there doing fun things at night. We've done many, many micro-elimination projects in our community, and I thought I was going to show a bunch of data, but I decided not to do that, and just say that one project, you start to get some success, and then you can just kind of build on that. And so we cleared Kool-Aid's 13 housing supportive sites, and they've been clear of HepC since 2017, 2018. And then we've sort of moved on to the shelter. So shelter isn't one and done. The shelter is still being tested constantly because we have people coming and going from community. We did a point-of-care HepC antibody pharmacy-led study back in the day in 2022 and found people through that. COVID sheltering sites worked really well as when the government moved everyone that was living in encampments into hotels. And we cleared almost 200 people with HepC at that time. And we continue to work with Vancouver Island Regional Correctional Center in corrections. What I'm most proud of that work is when people get discharged, either having been tested for hepatitis C or on treatment, that we catch them. So we haven't lost anyone, and we catch everybody in community, whether they stay in Victoria or they go somewhere else in BC or Alberta. Micro-elimination, I think, can also be done. And a lot of providers can do this, is actually look in your charts. If you can look in your charts and see who you haven't seen in a while that has a HepC antibody test or an RNA, we had a lot of success with this. And sometimes we haven't seen our clients for a while, or if they moved, sometimes they still do have the phone number. You can look at provincial databases too and find people. We were able to treat another 65 people that we actually didn't know were in our charts, which I was a bit embarrassed about, but it's a thing that you can do. We've expanded to also include these chart reviews in other OAT clinics and been really successful at that. Once you get one OAT clinic on board, other OAT clinics will get on board, so I think that's a great thing. We have 25-plus year relationships in some of the Indigenous communities in the South Vancouver Island, which includes Pacheedaht, Pakwachin, Sayout, Seacom. And so expanding on those relationships, we've recently been invited to Central Island into Cowichan tribes, and I'm really excited about that expansion. We know there is a work to be done in the Central Island. So I just sort of spoke about our prison work there. We do have a peer testing program. We've had one for over 10 years. It's morphed in from a weekly support group when that wasn't needed anymore. It's become this peer testing program. We have 14 peers, 3 currently work as peer testers. We also have volunteers that come to the program, and I'm showing a picture of Tyrone there next to Dean. Tyrone's a PhD postdoctoral fellow at the University of British Columbia, and Dr. Biondi and I just recently convinced him to go back to nursing school, so we're hoping he's going to go to nursing school at UBC. That's Dr. Marion Selfridge in the blue dress there next to our research assistant. All of our research assistants end up going to nursing school or medical school, so I feel like you end up volunteering in our peer program, and then somehow you get convinced to go on with your medical training or nursing training. Teresa, Brad, and Dean are also there. They are all Indigenous as well. And so recently, last year, I was at a nursing dinner, and Dr. Fontaine sort of said, and this was the first time I've ever heard of it, and it seemed like a good idea at the time. And I feel like that really spoke to me, and it really spoke to us at Kool-Aid. We have a lot of great ideas, but sometimes I think we always talk about our successes, and I'm going to tell you my absolute failures now. And one was Dr. Matthew Moore and I, we approached our medical health officers on the island, and we said, we'd love to do HepC RNA testing in your emergency. And we'd also love everyone to be HIV antibody positive, tested. And the emergency room physicians were like, sure, we can try that. And so they did for 6 weeks. They did HIV antibody testing with the plan to do HepC RNA testing after that. And in 6 weeks, we had 5 HIV positive cases in Royal Jubilee Hospital. And that promptly got shut down after 6 weeks. And I would say that, that's pretty successful. We found 3 cases that BC Centre for Disease Control knew about. So those people that were known to be HIV positive but off their medications. So that's huge, right? They got connected to Kool-Aid and now back onto their HIV medications. 2 other people are now being treated for HIV. And what ended up happening, and we weren't aware of, is that the ER program got a new centralized computer system. And when you order blood work as an ER physician, and you need to wait for HIV antibody testing to come back. It doesn't come back quickly. It takes a long time. And so that really screwed up the workflow. ER physicians at the Jubilee Hospital get triggered to go back to the patient and decide what to do once the blood work comes back. So workflow is absolute disaster. And so that's why that program got shut down and it wasn't able to work again. Had many other ones, but I think that really could use some help with that. I think that we would also find a lot of other HIV cases if we could sort out that. And I think if we could just go straight to RNA testing in Emerge, I would love to see that as well. My patients get 16, 17 antibody tests, never had an RNA test. And we need to figure things out like that. So future directions, and I think the future directions for programs like ours, when we get close to micro-elimination in our own city, is to sort of expand, but also to think towards the future. I think one day we're going to have injectable HIV treatment, hopefully HCV vaccine. I would love to see this program, and although it does a little bit of it, I was watching CanHepC talk with CTN Plus yesterday, and I think that this particular program and a bunch of other nurse-led programs across the country really are going to have the ability one day, and I would love to see implementation science help me and help us out with this, to integrate STBBI testing into this program, but not just that. I'd love to see HIV prevention be an option that we can also deliver in our program. And I would love to see CanHepC and CTN Plus start to break down some of the barriers that the BC Centre for Excellence in HIV has with accessing PrEP. It's a brutal program right now, in my personal opinion. There's a lot of paperwork. People need to actually access PrEP. The people that need it the most sometimes don't want to have that medication under their name, and that makes total sense. Remember that we provide STBBI testing at night in the dark in a place where people have anonymous sex. If I have to put a PrEP prescription under a patient's name, that all of a sudden is going to be an absolute no. I will never go on PrEP. I don't want that on my PharmaNet. I do not want my family doctor to know, and also my best friend is a pharmacist. And so those things that we have to think about. I put some pictures up there that I want to thank, Dr. Chris Fraser is our medical director. That's our Kool-Aid team there. I think, too, if we think about things in different ways, like the Wildfire Bakery, and we create spaces for people to put their artwork, it just creates more of a community. We worked for, I would say, about 10 years to get a designated street nursing parking spot on a street where we frequent the most. And the city of Victoria kind of said to us, well, no, what would we do, because we make a lot of money off of tourism. The tourists need to park there. And I was like, no tourists come down here. But anyway, so it took 10 years. And I think it's just persistence, and eventually you can get things done. And I also showed one of these. This is one of my favorite pictures with a cat. His name is Frankie. He lives in one of, not our supportive housing sites at Kool-Aid, but a different one. I've just put a black marker there because it's a patient's name I don't have permission to share. But one of our brand new nurses took this picture, and she's like, I was working in the building, everyone's smoking, so I'm wearing a full-out half-ass respirator, right? So that's what we have to do when we work inside supportive housing buildings now. And that's a lot of hard work. It gets really hot under that mask. And she said, I saw the sun coming in, I thought the graffiti was beautiful, and she took a picture of this, one of Frankie sitting in the sun, and I just really like it. It sums up street nursing to me. There's a lot of chaos, but there's a lot of beautiful things, and I would love to see some help with this program and to direct it where it needs to go in the future. And lastly, I'd just like to acknowledge, obviously, Kool-Aid Community Health Center. We never do anything in isolation. We always work with a team, and we always use a collective brain. Our clients, obviously, our peers. Thanks, everybody. Appreciate it.
Fabulous. Thank you, Tamara, for just such a compelling presentation that really underscores the long-term commitment and authenticity of the work that you're doing, and everyone at Kool-Aid as an exemplar for us all. So that ends our first morning session, and we're now going to move into a break. There's coffee available in the Grand Ballroom Exhibition Hall on the concourse level, and our next session starts promptly at 10:30, so look forward to seeing you then.